That takes us on to our next presentation. So next up, we've got Lance Slaughter's presentation, Making ALS a Livable Disease by 2030. So very much looking forward to hearing this one. Thank you.
A person is sitting in their neurologist's office, and the neurologist has just confirmed that they have ALS. The neurologist is also able to offer that this is the type of ALS they have, that there are multiple treatment options available, and this is the treatment option they recommend for their type of ALS. And the patient begins treatment immediately. That is just one example of how the future can look for the ALS community. The bigger picture is that with all of you, we're working really hard to find treatments and cures. In the near term, we focused on an ambitious but realistic goal to make ALS livable by 2030. Hi everyone, my name is Lance Slaughter. I am the Senior Vice President of Strategic Alliances and Governance, and we're going to be spending this session sharing with you our plans to help make ALS livable. I'll be doing this with Dr. Neil Thakur, our Chief Mission Officer, and we'll describe to us what ALS livable means, and we'll describe to you the things that we're going to be focusing on over the next 3 to 8 years to make that possible. We recognize we can't do this alone, so we wanted to share with you the 5 priorities we're going to be focusing on over the next 3 to 4 years to make ALS livable by 2030. The first 2 is to ensure people with ALS have access to effective treatments and cases of ALS are being prevented. We've committed to do whatever it takes to empower people with ALS to engage in the world in the way they want. We've committed to do whatever it takes to reduce the physical, emotional, and financial burdens of living with ALS. We're committed to ensuring all people with ALS and their caregivers receive high-quality services that benefit them. And with you, we intend to create a culture of accountability to ensure meaningful impacts for people with ALS. Those are the things that we're going to be prioritizing and focusing on over the next few years, and we intend to build on that work over the next 7 to 10 years. So, what does ALS being livable mean? Well, in part, we're going to be looking to fundamentally transform the experience of a person living with ALS and for the people who love them. Upon diagnosis, we expect people to start treatment that dramatically extends life and preserves function. Diagnosis will happen faster, perhaps before significant impairment. It might even mean that people are treated before they are symptomatic. It also means that people have the support to minimize the impacts of ALS and help them engage with the world in the way they wish. No matter the level of functioning, people with ALS will get connected to technology and support to have meaningful engagements with the community in the way they want. They get to be outside when they like. They get to talk with their friends, and they get to volunteer at their place of worship and other community organizations. If people progress in their illness, they get the services they need to reduce the complications of ALS, like infections, depression, and poverty. They spend less time in the hospital for falls and pneumonia, potentially adding years to their life. They have effective behavioral health care and ways to meaningfully engage with the world. They don't have to choose between financial stability for their family and getting effective treatment and care. And the neurologist, at diagnosis, will encourage the person with ALS to help prevent ALS in those they love, and the people who may share their genetic or environmental exposures that lead to their ALS to reduce that risk. Those are the things that we're going to be focusing on and prioritizing over the next several years. And we, again, recognize we can't do this alone. So how are we going to get there? With that, I'd like to call on Dr. Neil Thakur to share our ideas about ways to make this happen. Neil?
Thank you, Lance. This focus of making ALS livable has been really important in how we're thinking about how we do our work going forward. And so I want to talk through with you what we're going to do to make ALS a livable disease, to fundamentally transform the experience of having ALS. And so it's really three things that are pretty fundamental and straightforward, and I'll just talk through their implications. It's focusing on finding new treatments and cures. It's focusing on optimizing the treatments we have today, and it's preventing or delaying the harms of ALS. And so, of course, we've always been focusing on finding new treatments and cures, but it's hard to do. And you'll see that there's lots of clinical trials happening, but most of them don't result in successful treatments. That rate of failure is high. And it's high because we don't have some fundamental understanding of how the disease works or how to measure it. And the research it will take to get there, to figure those things out, is going to take a very long time. And so what do we do in the meantime? Do we wait? Do we put even more resources into finding those fundamental questions and again taking on this very long time horizon research? And the answer is we keep that going. But while that's happening, we focus even more on more clinical trials and running those clinical trials faster. And so there's a focus on the time to the benefit of the research that's coming to us through this livable disease framework. And there's also means that we need more people involved in clinical trials. And there's lots of people with ALS in the United States who are happy to take that on, which is wonderful. The second is, what can we do with the technologies we have now? In a fragmented health system in the United States, it's hard to deliver good care. Our care services staff spend a lot of time doing that. And we need to make sure we're doing the best job possible that we can, that we're applying the research techniques that we can to that space to optimize it. And so we're starting a quality improvement program through our care services and research programs together. We're working to improve assistive technology as well. So these things aren't necessarily going to result in a cure, but they are going to help make life with ALS easier. They maybe even help people live longer. And then the second thing, which is in some ways very much related to the first, is to prevent or delay the harms with ALS. And I get these emails or sometimes calls where someone with ALS has to go to the hospital, not for the ALS itself, but for some complication related to it. They have pneumonia. They're having trouble breathing. They're having some kind of terrible pressure ulcer or sore, or they've taken a serious fall. And I hate those. Yeah. And we do a lot at the association to help prevent those things, because we know they result in terrible suffering. They probably shorten life itself, the length of life for the people who go through those conditions. And so how do we do that better? How do we work with more focus, with more effectiveness, to reduce hospitalizations, to reduce complications? That's a key part of this prevention strategy. The second key part of this prevention strategy is more like classic prevention, of how do you prevent or delay people getting ALS in the first place? And so there's lots of genetic treatments that are genetic forms of ALS that have been identified. And some of those genetic forms are under study. We're developing treatments to suppress those genes or to prevent them from being expressed. So to make those treatments work, if we find out they work, to make them work in the real world, we have to make sure people get tested. And so that's something that we're starting as well, more widespread genetic testing in the United States, because we need to be ready for when those genetic treatments are identified, so we can start applying them effectively to everyone. Another aspect of this is we're starting to find out that a lot of treatments seem to have a better effect when they're applied earlier in the course of illness. And it's easier to plan for the disease, it's easier to manage the disease if people have more time to do that work, to do that planning, and we have more time to get them the benefits they need so they can get their care paid for. So that's why early diagnosis is really important. I think the traditional experience has been, and Lance has talked about this, that people get their diagnosis and told there's not much they can do. That's not true. And so we're working on a focused effort to reduce the time to diagnosis in the United States. And we've been drawing from work that's been happening in other countries. And that can be really important to make everything work better, because it's more time to treat people. And then finally, we need more formal ways to simply assess what are the risk factors, and turn that knowledge about risk factors into practical information. Maybe there's ways that people who are at risk for ALS can modify their risk, modify their exposures over time. So this is all part of a complex plan. We have a 2030 timeline. We have an immediate strategic plan. They all do fit together, these different time horizons. Our current strategic plan is a way of getting us to 2030, and this 2030 concept, putting this time frame on us, makes us think a lot more about the time to the impact of the activities that we're doing, and then also how to make the best of what we have available today. So people with ALS can just frankly live high quality lives until the treatment that can change their experience comes. So thank you for that. I look forward to your questions.
Thank you to Lance there and Neil. Thank you so much. You can see me and hear me, hopefully?
Yes. Good morning.
Excellent. Good to see you. Thank you for joining us. That was fantastic. I mean, what great aims and ambitions and focus this. I've got so many questions, but I'm going to try not to dominate asking them all. I'm going to go to other people. But having said that, I do want to ask the first one. So you talked about reducing time to diagnosis, and this is something we and every country sees. We want to improve that time. I was wondering whether you could expand on that and tell us a bit more about how you plan to do that.
Yeah, there's a couple of things. So you may have seen Dr. Yursak's presentation last night where she introduced the Think ALS tool. That's targeted at neurologists in the United States, primarily because we think neurologists outside of ALS specialty centers are the ones that get involved in the diagnostic path relatively early. And but that group is a small enough size for us to manage. If we were to take on all primary care physicians, we're talking about, I think, hundreds of thousands of physicians, and it's a much bigger group. So we'd like to start with the neurologists, and then there may be other specialists who get caught up in that diagnostic pathway or bad diagnostic pathway. And so we can expand out depending on how things go. I think the other thing we need to work on, and Dr. Carter's presentation really brought this out, is we need to do a better job of aggressive case finding. In the association, there may be groups of people, different cultures, different language groups, different parts of the country that don't get diagnosed, that aren't getting the benefit of association services. And we need to work on ways to do community outreach to find these folks and to provide what help we can. So those are two paths. And I think that's just the beginning. As we get better biomarkers, as there's more conversations about genetic testing, I think we can make improvements in those areas as well.
Mm. I'm nodding away, Neil, because we have the same questions as well around access to communities and things like that. There's a question that's come in about how do caregivers fit within this plan? It's quite a good question.
Yeah, caregivers are really important. And unfortunately, I would say that's an area that hasn't received as much attention from our research program, but it's been a pretty big focus of our care services program. And I think that's part of being a small disease. In the US, there's a lot more documentation about the burdens of caregiving, the injuries, the psychosocial impacts of caregiving in other disease areas like Alzheimer's, because they've had the resources to put in the time and collect the data, whereas we have not. And so that's something that we'd like to do more of in our research plan. And we'll talk about that in a bit in the next session. But it continues to be a major focus of our care service program. And part of that is we need to think about ways to systematically assess what's going really well in care services and then share those successes. And I got to see a lot of exciting presentations yesterday from some of the other associations talking about what they're doing for care planning and decision making. They're also doing a lot of education. We're doing a lot of education. And to be able to tie those interventions to specific outcomes like hospitalization rates, for example, for injuries related to transfer or taking care of people, that has a caregiving component. I'd like us to find ways to track the stress and burdens of caregiving on the caregivers themselves. And you saw Dr. Parvanta talk about the focus program. That's one way we have of serving not only people with ALS, but caregivers as well. So there's a lot of work to be done there. And I think we need to do even more to really flesh that out and to think about the supports. And then let's not forget, in the US, we don't have great support for long-term care. And our advocacy program has been working to help people get benefits, and those benefits provide some relief and offset of burden and time for caregivers, but it's not very much. And so we need to think about better policy solutions. But that situation may be different in different countries.
Yeah, thank you, Neil. I was reflecting on the same thing, which is this question that's come up, which is, there's a lot there, isn't there? It's very ambitious, and that's brilliant. And the question is, thank you for the presentation. I like the ambitious goals. How realistic are these, in your opinion?
Would you like to take a start?
I was going to say, so part of it is that when we embarked on building out our strategic plan, we typically, I think, set some goals that were ambitious, but quite frankly, didn't create the amount of fear that the ambition deserved. And so we were challenged, in particular, by our CEO, Kalani Balaz, to basically speak beyond our current capabilities. And so it was a rather rigorous conversation in terms of establishing both not only an ambitious goal about making ALS livable. Clearly, we needed to define what that meant to us and be able to share that to the ALS community, but actually make an ambitious goal time-bound. And although that did have some level of controversy, not reflecting the level of urgency that the ALS community is feeling, we thought that was at least somewhat reasonable with respect to creating enough urgency globally with all ALS and MND organizations to move toward that target with a 7 to 8 year time frame. But at the same time, we also embarked on setting these very immediate goals, those that we could achieve by 2024. And what we've done is create a plan that essentially creates intermediate, short-term goals, and we build on that work. So this 2030 ambition, this goal of making ALS livable, is actually going to be informing the next 3 strategic plans that the association has. We also thought it was important that, because of its ambition and with a healthy dose of humility, we had to recognize we couldn't do this ourselves. So this forum, this opportunity to share this with all of you, actually gives you some information in terms of how we're thinking about ALS and MND, and ask you to embed some of these ideas in your own thinking and your own planning. And it's in that spirit that we have a good amount of confidence that we can get there by 2030.
And I would add to that, that the time horizon is really important, because it forces us to think in a very specific way. So if we're just trying to think we need to find a cure or cures for ALS, and that's our single most focus, then taking on a 20-year study or finding the 35th or 36th gene that may be implicated with ALS becomes just as important as getting the 5th gene into clinical trials. And it's really not. There is, if we want to have an immediate impact and we want to focus on impact with people with ALS, then the time horizon leads us to certain situations. So it does mean we need to get more things under study right away. It does mean we need to pay more attention to why people are going to the hospital and dying today. And then as we start to get successes, we need to think about how to rapidly shift our enterprise to meet those challenges. So new drugs are going to come out and they're going to work, and people are going to live longer, but perhaps not be completely cured. So we're going to have to support them. And as we get more treatments into clinic, we're going to have to figure out how these treatments work in combination with each other. And those aren't simple questions, so we need to be ready about it. And that clock is ticking very quickly. So I will talk about this a little bit more in our research session. But
excellent.
Time to impact has to be the overwhelming focus of what we're thinking about when we do any kind of planning.
Yeah, thank you so much, Neil. Thank you, Lance. It was very informative and very ambitious, and I wish you all the best. I'm looking forward to watching from afar and seeing. Please do keep us all updated as to how that progresses. So it's yeah, thank you so much for your time today. Sorry, I'm having to wrap up quickly, but we're on a schedule. So thank you so much.
Absolutely. Thank you.